Well, welcome back we're going to get started on the second session on neoplasia here. The first off for the second session will be, again, my partner Mark Osborne talking to us about increased colorectal cancer in millennials.
Thanks, Brett. Increased colorectal cancer. And I got this from Wolf. It was millennials, exclamation point. I don't know what that was about, but I attacked it as such. What is a millennial? The risk of colorectal cancer is increasing. Why is it increasing? And what can be done about it? I have no disclosures. Technically, I am not a millennial, but the older I get, the more I act like one, perhaps trying to hold on to my youth. What is a millennial? It's a person in the United States born roughly between 1980 and 1994. So I was born in 1979. Don't tell Ann Lowry, she hates it when I point that out. It's currently between the ages of 38 and 24 years old. The couple things that, there's a lot of things about millennials, but really the unifying things is that they've adapted to tech their whole life. I mean, tech has changed constantly through their whole life, and so they're adept at adopting new technology. They tend to be more socially liberal than older generations of Americans. They experienced significant effects due to the Great Recession. I can tell you that all of my younger brother and sisters moved home directly after college. That was not even a thought in my mind as I graduated from college. Why would you want to move home? They get blamed for everything. They're lazy, they're entitled. There are endless, and I mean endless number of articles of how millennials are ruining ... movies, nobody goes to movies, dating, marriage, divorce. So how do millennials respond? With memes. This is Ann Lowry's high school boyfriend, I think. Drives up the federal deficit for 30 years, hands the bill to his kids. Remember when we cried as kids and our parents said, "I'll give you something to cry about"? We thought they were going to hit us, but instead they destroyed the housing market, quadrupled college tuition, and melted the ice caps. So on to more serious topics. Colon cancer, it's common. If you work in the state of Minnesota, there's going to be about 2,000 new cases, more than 2,000 new cases of colorectal cancer and 760 deaths for a rate of about 35%, whereas for breast cancer, there's going to be close to 4,000 new cases, but only 620 deaths, so it's common and deadly. And the incidence is changing. So overall, colorectal cancer incidence has been declining, at least since 1975. It declined 3% annually from 2003 to 2012, at least according to SEER data. Experts think that decline between 1975 and 2000 was half risk reduction, half uptake in screening, so less smoking, less red meat, things like that. But that from 2000 onward, it was primarily driven by screening. But unfortunately, over the same time period, the risk and incidence of colorectal cancer in patients aged less than 55 is increasing, and in fact, it has increased 51% overall since 1994. So these two graphs are right out of analysis of the SEER data. So on the top chart, you can see that's the rate of new colorectal cancer cases per the year interval noted on the x-axis for patients aged 20 to 94. So you can see, there was a little bit of a drop-off between 1975 and 1994, but that since the 90s, it's been slowly increasing. However, for the geezers, the incidence has been decreasing of number of new cases per 100,000 in patients aged 50 and older, a nice steady trend on downwards. So not only is the incidence increasing, but it's getting worse by birth cohort. This is an analysis from Dr. Siegel in which they did a forget the exact name of this technique, but it's kind of like a cohort analysis that essentially tries to look at when you see these big changes in incidence of a disease over time, is it environmental factors, is it changes in medical care over time, and what's going on, and what they see here. So this is the birth cohort on the x-axis. On the y-axis, that's the ratio of your risk, depending on which birth cohort you're in, versus the baseline risk. And so the baseline risk is the cohort born right after World War II. So they've experienced the lowest incident risk in their lifetime. And so the scary part is for those of us born near 1980, we are experiencing the highest risk, particularly of rectal cancer, in over a century. Similar way to look at the SEER data and just analyze it a little differently. We can see that these are the younger cohorts, 20-year-olds, late 20-year-olds, early 30-year-olds, late 30-year-olds, and over time, the incidence just keeps marching up, while for older patients, they're seeing a drop-off, particularly over the last decade or so. So in the early 1990s, the incidence of colorectal cancer in, say, a 50 to 54-year-old was half that of a 55 to 60-year-old. But now in 2013, the incidence of rectal cancer was the same within these two cohorts, and the difference in colon cancer was only 12%. And sadly, 30% of new rectal cancer cases in 2013 were in patients aged less than 55. So why is it increasing? So this slide summarized some knowledge of what we can definitively say of why this is increasing. So if anybody has the answer, says, I know why this is happening, they are lying to you. But I did find this paper done by Heather Yo out of the group at Cornell, and she looked at the SEER data for a little bit more recent time period of 2000 to 2011, as well as looking at the Cancer Genome Atlas, and she compared early colorectal cancer, so these are in patients aged 20 to 50, and traditional colorectal cancer, which is those that develop the cancer after the age of 50. So as you can see, as expected, rates of traditional colorectal cancer decreased 3.1% per year, while as those early colorectal cancers increased 1.4% per year. But the interesting thing is that when they looked at the incidence change year to year of where these tumors are occurring within the colon, the incidence increases in a stepwise fashion from the ascending colon to the rectum. So that means that for these young patients, year to year, the overall risk of cancer was increasing, but it's not uniformly distributed throughout the colon. So for example, the incidence increase in the transverse colon was slightly higher than the ascending colon. The incidence increase in the descending colon was higher than the transverse, sigmoid higher than the descending, and rectum highest at all. When you see something like that, that kind of makes you think. Additionally, they found that these incidence changes, so the incidence increasing higher in men, African-American men, men, African-Americans, Hispanics, and then there's a much higher rate of distant disease. There was differences, and we can argue about whether this is clinically significant or not, but a doubling of the signet ring, as well as a small change in mucinous pathology. Again, this doesn't tell us anything why, but it tells us just what's going on. So one thing that can be done about it, or what can be done about it, we can change our pretest probability, we can screen earlier, and we can combat the causes if we knew them. So I think this is just, my plea. I think that just as we've educated the wider medical community that not every patient who has 2 attacks of diverticulitis needs a surgery, I think we also need to spread the word that we can no longer ignore symptoms of, when patients come with new constipation in their 30s or some rectal bleeding, we can't just tell them, oh, it's hemorrhoids. I think people in this room know that instinctively, but unfortunately I've seen way too many cases where symptoms like this have been blown off as hemorrhoids or just some constipation, and That's because people are previously operating under the assumption that a disease like this is rare in 30 and 40-year-olds, but when in fact a third of new rectal cancer cases are coming in young people, it's not that rare. So based on this data, the American Cancer Society decided to re-look at their screening guidelines. So the guidelines, I think we all know them. They tell us, when to screen and how often to screen and with what modality to screen. And we shouldn't kid ourselves that this is based on any level 1 data. It'd be very, very difficult to put together a multi-armed trial comparing all these screening modalities, as well as stratify patients into different time frames with when you might start screening or end screening. So when you don't know, you can kind of just make a model and feed all the data into the model and see what the model says. So there have been 3 groups that have looked at this. The first is the RAND Corporation. The second was a collaboration between a university in Europe and Harvard, and the second was a collaboration between the University of Minnesota and MIT. And these are not perhaps the usual cancer researchers that you're thinking, the clinicians that publish a lot in the papers. These are the nerds with supercomputers. And they run microsimulation models, and they ask the computer, well, what would happen if we start screening at age 40 or 45? And what would happen if we screened more frequently, like every 5 years with a colonoscopy, or every 2 years with a fecal occult blood test, or CT colonography, and they can plug in all these various modalities. So this was essentially how the U.S. Preventative Services Task Force came up with their estimates of when to stop. So I think we know that they've recommended for a while now that you should consider stopping screening at age 75, and that there really isn't any rule for after age 85. So the American Cancer Society independently employed 2 of these 3 groups and rerun the data, but instead of using historical data, which is what the U.S. Preventative Services Task Force had done previously, they had the groups run with updated new incidence data, and this is what they found. All right, so on the x-axis here we have, this is colonoscopy, CT colography, flex-sig, FIC testing, fecal occult blood testing, and this is the multi-targeted stool DNA, also known as Cologuard. The gray bar is what the microsimulation estimates if you screen from age 50 to age 75, and the blue bar is what the microsimulation estimates for age 45 to 75. And what it basically shows you on the y-axis is life years gained. So you can find that for each modality, you're going to save more lives if you start screening earlier, and that colonoscopy picks up the most cancers and saves the most lives. Somewhat known intuitively in that the colonoscopy has the best method for detecting cancer as well as precancerous lesions. So therefore, earlier this year they came out with their qualified recommendation to begin screening at age 45. They still recommend at a strong recommendation level that patients should be screened at age 50. The reason they really qualified this recommendation is that they said, look, like all of the big trials in screening didn't include a lot of 40-year-olds, and the question is really what's going on. Is something going on with a different biology? This doesn't seem to be just more of the traditional cancers, that there's something biologically going on, and so therefore is it appropriate to really attack that sort of problem by just increased screening? But when all you got is a hammer, everything's a nail. So that's where we're at. So overall, the rates of colorectal cancer are decreasing due to environmental factors as well as better uptake in screening. But the rates of colorectal cancer in young patients are increasing largely due to unknown factors. And we should know that the American Cancer Society has changed these recommendations with regard to when to initiate screening, but the implications for this as far as widespread adoption as well as the whether or not patients can get this paid for remains to be seen. Thank you.